Hello and welcome to the webinar eReferral, Transferring the Referral Experience. This webinar is brought to you by Orion Health and eHealth Space. My name is Josh Glidden and I'll be your facilitator today. Today's guests will look at how the province of Alberta in Canada has fundamentally changed the referral experience using digital technology. Our guests are Dr. Chris Hobson from Orion Health and Dr. Allen Ausford from Alberta Health Services. I'd like to hand over to Dr. Hobson. Dr. Hobson is Chief Medical Officer with Orion Health based in the Scottsdale, Arizona office. Prior to joining Orion Health, he worked in hospital strategic IT roles and before that as a major primary care physician in Auckland, New Zealand. His areas of responsibility include ensuring the clinical suitability and adoption of Orion solutions, and his current areas of particular interest include eReferrals, care coordination, privacy, and clinical safety. Dr. Hobson, over to you.
Thank you, everyone. Good morning. As we heard, my name is Chris Hobson. I'm the Chief Medical Officer with Orion Health. I just wanted to say a couple of words ahead of Dr. Ausford's presentation about the project, and like to emphasize that the work was done as a partnership, and I really think that partnership between the vendor and the various client-side participants is a really successful model. So for Alberta, we had, as well as Orion Health, we had Alberta Health, which roughly translates as the Ministry of Health for Alberta. Alberta Health Services, which is the secondary care hospital-based provider of services across Alberta, and the Alberta Medical Association, representing mainly the physicians. What we aimed to do was to take the existing highly successful electronic health record that's deployed in Alberta, known as Alberta Netcare, and then add to it the eReferrals component and configure it so that it made most sense for the for providers and services on the ground in Alberta. Next slide, thanks, Josh. So, you know, in terms of keys to success, again, so especially with the partnership, also what we did, we took an iterative and agile approach. So we already had a basic format for how referrals should work, some understanding of the forms and the workflow that should be followed. We worked closely with clinician advisory groups to get clinician input, started small and went successfully live with those with the initial projects, and then built that so that now we have a very good eReferrals product, which we feel we can take to other sites as well as just Alberta. So what I'm going to do next is introduce you to Dr. Ausford and then hand over to him. And I'll be here right through the webinar, and Alan and I will answer questions at the end as they're raised. So next, there's a picture of Dr. Ausford, and in the next slide, thanks. So Dr. Ausford is a very respected physician in Alberta circles and across Canada. His primary role is a primary care physician in Edmonton, Alberta since 1981. He's worked as Chief Medical Information Officer for Alberta Health Services, as a clinical professor for the University of Alberta. He advises the Alberta government on e-health policy, and he was deeply and heavily involved in the development of both Netcare and the Alberta eReferrals project. So I highly recommend him to you, and thank you, Alan.
Hello, everybody. Hello from Canada. It's 4 o'clock in the afternoon here, and it is 4 degrees centigrade. And my assumption when we get to the question time period is we're far enough along the timeline that I'm allowed to open an Australian red Shiraz as you're asking your questions. So we'll move to the next slide if we could, please. We're basically going to talk a little bit about referrals. And, you know, I'm assuming there's a lot of clinicians as well as administrators as well as IT people in the audience. Referrals can be a challenge, and this is a classic example of a simple, useless referral letter that is an actual real example of one. If we go to the next slide, you'll see yet another one, where what we're running into is people are inappropriately not providing the appropriate information. People are not going through the proper processes. They're not making sure that things are complete in the way that they go through things and that. If we go to the next slide, just to show you a little bit about the country of Canada, Alberta So provinces in Alberta are equivalent to your states in Australia. So Alberta basically is one of the western provinces. I live in Edmonton, Alberta. Basically, the province is a population of about 4 million people. Alberta Health Services is responsible for the delivery of all health care to the entire population. So it is a government-funded service that we provide to all of our patients. We have some small private one-off type situations, but they are not comprehensive and they're only for very small types of things. Edmonton is a city of about 1 million people. The other major city in Alberta is called Calgary, and it's about 1 million people as well, and they have a far poorer both hockey and football team than we do. We go to the next slide. So just to sort of frame things a little bit, often there's terminology differences depending upon which jurisdiction you work in or live in. What I've put on this slide is just the basics of the difference between what we call an EHR, but often EHRs and EMRs can be confused in the terminology. So I'm going to use the word Alberta Netcare for everything I talk about when we talk about the product we're dealing with. So think of it, my understanding I think is you have something called the Open Platform Health Information Exchange, HIE. So think it's a health information exchange, it has a provider portal, and it is a go-to place to have aggregated information, which is different than the EMR, which is a more, if you want, provider or organizational centric tool. The current EMR that I use is Epic Ambulatory, which you may be familiar with, and it is a different product than what we're talking about. So everything from this point forward that I'm talking about is off of the Health Information Exchange eReferral module. It is not in the EMR, although there is integration and some interoperability between our EMRs and the EHR that we can talk a little bit about later. So if we go to the next slide. So Alberta Netcare as a health information exchange basically has a number of modules or another number of pieces to it. We have a provider portal, and what that means is you can actually go on a web-based access and see all of the information in there, as well as integrated with most of our EMRs. So you can be on your EMR, push a button, and immediately have all the data available that you need to within the EMR in terms of a view. We have what's called the EMR context launch, and so that means if I'm on Mr. Smith in my EMR and I want to quickly see what's on the portal, a single button I push and immediately I'm there. So you don't actually have to do a search again when you're on the portal. We have case management, a lot of chronic disease management that we do there. We have diabetes, we do congestive heart failure, we do a COPD, those kinds of things that we actually hang off of the provincial HIE as opposed to just our EMRs, because a lot of different care providers are using different EMR systems, so we try to aggregate at that HIE level. We also have our pharmaceutical information network, which basically has most of the dispensed medications from all of our pharmacies available. We have PACS viewers, PACS systems, where you can see images and reports pretty well across the province. We have a population health dashboard that tells us about the status of certain populations. For example, I can tell you at a push of a button that I have 1,394 patients as of yesterday, and I have 110 diabetics in my panel. So we were able to look at those kinds of things and be able to do population health and see what we're doing that way. We also have the system linked to the ADT systems within our hospitals and our outpatient facilities. And what that means is we can generate lists automatically and hang them off the Health Information Exchange. So my rounding list when I make rounds at the Misericordia Hospital is there. I have another list that shows any patient who is within my panel that is doing anything within Alberta Health Services from an events perspective is visible. So I can see who's in an emergency ward in Calgary. I can see who is attending an outpatient facility for diabetes education across the city. I can see what's happening with my patients within the system. We also have basic messaging within the system that's in a secure fashion. We have a number of resources and links as a quick button where you're sitting behind the firewall within Alberta Health Services to get at information. We have what's known as a data integrity button. If you're looking at some data within the system and you discover that there may be some problems in terms of the data, you can very quickly send a message saying that there's a problem. For example, a male with a positive pregnancy test. We could very quickly send that to the data team and say, look, there must be some problem in terms of our EMPI or some problem in terms of our matching, and that needs to be fixed. We also have an enhancement request button, so people can push that and say, you know, it'd be really great if the system did this. And in fact, that was one of the things that generated us building the eReferral module, was hearing from people saying that it would be great if we could hang referrals off of a provincial-based system as opposed to a city-based or a single EMR-based system. And so that's what we're going to talk about today, is the eReferral system. So if we go to the next slide. So within Alberta Netcare itself, this is the percentage of things that we actually have within the system. So it's a very robust system. It has a huge amount of data going back to 2004. 96% of dispensed medications, 92% of all lab data, 92% of all diagnostic imaging, and in fact we're just, I think this next month, crossing the 300 million screens of information viewed by providers. Next slide, please. So just to give you an idea in terms of users, a lot of people think a health information exchange is for physicians only, and in fact it's not. If you look at the statistics that you'll see in the percentages here, you'll see that it is used by all kinds of healthcare providers and allied healthcare providers. It is also used by administration. It's also used from a supervisory perspective as well. So it's, we have just under 40,000 active users of this system that are using it on a day-to-day basis, sort of thing. Next slide, please. So finally, we can start talking about eReferral. I wanted to just give you a little bit of background in terms of why we chose to hang it off that system, because it's a very robust system that's used by a lot of people. So in looking at referrals, this diagram basically shows you what we consider to be the important key timestamps when it comes to doing referrals. So you'll see there's a time 0 all the way through to a time 10. There's a referral wait time component, there's a service wait time component. And what we're doing with the system is we've set it up so that we can track all of these times in real time, and we can make available what's going on in the system. What that does is it allows us to look at bottlenecks in the system. So we may find that there's a problem between the time the appointment is booked and the time the patient attends, in which case we need to deal with our clinicians, or we may find that there's a problem somewhere else within the system as well. And so it allows us to generate statistics and actually display those when people are doing referrals. So this is our sort of map, if you want, in terms of how we want to make sure that we're doing appropriate analytics in the system. Next slide, please. So in developing this, in 2013, between February and April, we put together a design team. And basically we had 9 meetings, roughly once a week, across the province of this design team. There were 12 voting members on the design team. We had 15 support members, both from Alberta Health Services, from Alberta Health, which is the Ministry of Health for our province, and from Orion Health as well. And what we did is we put together some terms of reference, but most importantly what we did is we had guiding design principles. So we had principles behind what we wanted this to do, and we made sure that we stuck to those design principles as we went through. I think the other thing that we did that was very valuable is once a week there was a teleconference that was open to anyone within the province, and it was attended in a big way for people to see what we had done at our meetings and what our thinking was and what our next meeting was going to be about. So we had a vetting process to a huge number of users, clinicians, triage people, medical office assistants, all those kinds of people, where they could have some input, and we would receive that input prior to our next meeting. So although it was iterative, we really made sure we were feeding it out literally on a weekly basis to try and tune this to what we thought our users would want. And finally, we got to the point in July where we did a limited production rollout. And we'll go to the next slide. In doing the limited production rollout, basically, we wanted to make sure, oh, sorry, I should tell you about the key requirements. I'm one slide ahead of myself here. The key requirements when we did the development was it needed to be right across the province or state. It needed to leverage the fact that we had a very rich data source in Netcare and that information was there, and why should someone have to reproduce it yet again when they're doing a referral when we already have it in digital form. And digital form doesn't just mean, structured data, it also means PDFs, and it means that we sometimes even have sort of simple documents that are, as long as they're categorized in terms of a name, that can be used within the system. We wanted it to be very user-friendly. We wanted it to be team-based. It needed to support anything from a one-to-one referral where a family physician simply refers to a surgeon, and those are the only 2 people that look at the referral, versus a system where a number of staff at one office are responsible for putting together a package that sends to another set of people, and those people have triage and they have all kinds of other steps. So we wanted it from simple to complex, and it needed to handle both of those situations. We wanted to be able to track and triage easily. We wanted to be able to do that both at a referral level and at a wait time level. And finally, we wanted to have a health services catalog so you could slice and dice the ability of what you're doing and who you're referring to, and make sure you're referring to the right person in the right place at the right time. And we'll talk a little bit about the health services catalog and how we develop that. If we go to the next slide, it needed to be simple. So there's a searchable catalog. There's the ability to start a referral, save a draft, allow it to be added on later, sort of thing, in case you needed a single thing. Let's say you needed an x-ray back before you're sending off the hip replacement referral. You could start the draft and then do it after. We needed checks for completeness, which meant before the system allows you to actually send the referral, it makes sure you have the appropriate stuff, which saves the churn of sending it, then hearing that there's some information required, and then it goes back and forth and back and forth. So we have those checks built in where there's minimum requirements that people receiving referrals will set. We wanted it to be timely, so again, we didn't want to have to duplicate work, so grabbing information directly out of Netcare was important. We wanted to be able to delegate authority. If I wanted my medical office assistant to do most of the referral work and I simply do the pertinent paragraph, we could do that. We wanted to be able to share it amongst a pool of people if that was required. And we wanted people to be able to look at the history of referrals and see what was going on and know what was happening in real time. We also wanted it to be personal. And part of that is a concept that we developed, the difference between a referral that is a formal consult and a referral for advice. We found when we talked to our specialists, most of them told us probably 50% of the referrals they received, they probably didn't actually need to see the patient face to face. They actually could look at all of the information and give advice back to the referring person, and they could move forward on something. Now, of course, it's not the same when you're doing things for procedures like surgery or colonoscopies or gastroscopies, but it certainly is when we talk about, say, an internal medicine referral or dermatology referral where you could attach a picture to it, those kinds of things. So the system allows you to do a referral for advice, and providers could state whether or not they were willing to receive a referral for advice, and that often made very, very fast turnover times where literally you could send a message, you get the message back, you move forward. You didn't have to wait the 3 months for them to see the person for them to tell you that one line that you needed back in terms of where you needed to go next. We wanted to be able to track the referrals in terms of what status the referral was at and whether there are any delays, and of course we wanted it to be universally accessible, and that's why it's a web-based product. The next slide, please. So we finally got to the limited production rollout a little over a year ago. We picked 3 areas to do, breast cancer, lung cancer, and hip and knee joint replacement. The reason we picked those 3 was for a variety of items. Number 1 is those had provincial existing programs already. They were fairly standardized already. Number 2 was they were fairly topical in that we, in particular in lung cancer and hip and knee replacement, there's been a lot of press stating how long waits were for these situations, and so they were very topical at a government level in terms of trying to solve a problem and improve the time we had for referrals as well. So those are the reasons why we picked those. Next slide, please. So what I'm going to do now is just run you through some of our screens. We're not doing a live demo, mainly because of the latency issue when we're doing all of these things through a WebEx, but also in order to do a demonstration, I would have to do it on our training system as opposed to our production system for privacy reasons, and the training system isn't as robust with information. The other thing is if you have copies of these slide sets after, it gives you a little bit more of a hard copy if you want in order to see. So the first slide you're seeing right now is the typical home page for a provider. So myself as a family physician, when I log into Netcare, this would be my home page. And I can configure this home page in any way I want. Each one of those major areas, the My Referrals, the Patient Search, the Triage Referrals, those are each windowlets. And I can actually go into the system and configure whatever windowlets I want on there. And what I'm showing you is a typical windowlet of somebody who would be using it where referrals were important to them both in sending and receiving referrals. So you'll see that there's a My Referrals and there's a Triage Referrals area there. As well, you could quickly search for patients. You can also look at patients you've reviewed in the past time. But again, you can configure this page in any way you want, sort of thing. The other thing you'll see on this is you can start to see a little bit of how we've divided out all the categories. So for example, in the triage referrals, there's a difference between drafts versus undelivered versus triage, whether or not information is being reviewed, whether the actual appointment is waitlisted or deferred, how many are scheduled, and how many are actually done. And so we'll go a little bit through that again in some of the other screens. So if we go to the next screen, please. So the health services catalog was, I think, a fairly innovative thing that we looked at. What it comes down to is we want any provider within the entire province of Alberta to very quickly be able to find out who does what, where, and when. So you can slice and dice this in terms of the provider. If you know I always refer to Dr. X, you just find Dr. X and away you go. But if you wanted to refer just to a specialty, you can. If you wanted to just pick a reason for referral, I only want to see the guys that do right toenails and nobody else. You can actually pick the reason for referral, and only those people that do those reasons are in the thing. You can also divide it in terms of facility. We often will have patients that say, I want to go to the Misericordia Hospital. I don't want to go to the Royal Alec Hospital because I had an aunt who had a problem at that hospital and I never want to go near there. So again, you can slice and dice it in any way you want. You can also set it with defaults, for example, because I work in Edmonton, then the Edmonton zone basically would be automatically checked, and so most of my referrals would default right away to just the Edmonton area. But if I wanted to, I could go to Red Deer, which is about an hour down the road sort of thing, if I really want to try and find somebody who can see something sooner sort of thing. The other thing you'll see below are sort of existing referrals that may be in the pipe that I've been working on and things like that as well. Let's go to the next slide, please. So reason for referrals and requests. So basically, as we put this together, you would pick, say, a hip pain as a referral, and you're doing a consult to orthopedic surgery. What happens when you're doing that is, again, you can actually see the things that are in progress, and you can start to create your referrals. You have the ability to track what's going on. We're now at a patient-centric level on the Health Information Exchange. So you'll notice George Simpson at the top of the screen. We're now on George Simpson, and I am doing a referral for George Simpson with hip pain to orthopedics. And at the bottom of the screen, you'll see that George Simpson, because this is our training database, has a number of other referrals to orthopedics. So it's a quick way of seeing, you know what, somebody else has already referred for something pertinent. So those patients that don't have an identifiable primary care provider for continuous care and tend to go to walk-in centers or those kinds of things and may have many referrals in the pipe, any referring person can see that in fact they have other things on the go sort of thing. And so it's a good way of making sure that we're not duplicating referrals. And it's also a way of looking down the list and saying, you know what, they've already seen an orthopod 5 years ago for a hip. Maybe I should be sending them back to the same orthopod for the other hip. And so it's a good way of being able to see what's going on from that perspective. As well, in the refer for, that's where you can select whether you're doing a referral as a consult or a referral as advice. And if it's advice, you're simply asking for a message back where they would review the questions and then tell you what's going on without having to do a formal in-person referral. If we go to the next slide. So once you're doing the referral, the other thing that we found was very important is leveraging the Health Information Exchange. So you'll see here that as you're going through, there are sort of minimum requirements for doing the referral. So for this particular referral, there needs to be a chest x-ray and a CT, either ordered or attached. And there's other requirements as far as things go that way as well. And so you can very quickly sort of know exactly what the person you're referring to requires and make sure you've met all those requirements. And in fact, if you, some of these are hard-coded, so if you haven't attached things, the referral will tell you, no, you still need that specific x-ray or you still need that specific lab test before you can send this referral off. And that's where you would save it as a draft, order that test. As soon as the test is back, often your medical office assistant would see that, pull it up, attach it, and then send off the referral. The other thing is you can attach things to the referral. So when people are receiving these, they're already on Netcare. So if they need to, they can go browse and look at a bunch of things in terms of lab data, x-rays, medications. But in fact, we attach specifics. So if this was a hip referral, for example, I would attach the hip x-ray by linking a document, and that's where the link a document button is. And remember that those documents do not have to be structured data. They can be a PDF. It can just be a report. It could be anything that you have that you think is of value in the referral and that you have within your Health Information Exchange can be attached. And then there's questions below about sort of topping up the information in terms of what that referral requires in terms of knowing things like comorbidities and those kinds of things as well. We'll go to the next slide. So now we're looking at it from the other side. What I was showing you to begin with was somebody doing a referral, generating a referral, putting it together and sending it. This is somebody receiving a referral. So you'll see that there's a triage dashboard, and you'll see that they actually, when they receive a referral, they categorize it. And it may be, for example, reassigned. So a reassigned referral, a classic example of that is referring to somebody who's away for 6 months on sabbatical. Well, they know that someone is covering for them, they can reassign it to another provider. Or it could be that it's assigned initially when they receive it to waiting for a clinical triage, or that there's a triage in progress, or that they're waiting for the clinical triage to be completed, sort of thing. And all of these categories allow you at a glance to see what the status is of the appointment. So if you look below and see, for example, one of the George Simpsons, there's more than one George Simpson because, again, it's a training base database, you'll see that if you scroll over to the status area, that person is waiting for an appointment. And so you can actually see who last modified it 2 days ago. You can actually see, the targets that we set. So, for example, we set appropriate wait times for certain types of referrals, and if it's under the target, it shows up in green. If it's over the target, it shows up in red. You can sort any one of these columns by clicking on it. So if you wanted to say, show me all the ones that are past our usual target date for referrals, you can immediately sort to that, and you can get on those right away and make sure that those are being fast-tracked or dealt with if there's something holding them up. So it's a very slick way of the person doing the triage and managing from a dashboard perspective the numbers of referrals. And this is commonly used in our larger organizations. So for example, in Edmonton, there's a single area to refer all hips and knee replacements, and then that is basically fed out to the different orthopedic surgeons to do their job. So you can imagine that, in a city of 1 million people, there are a lot of referrals for hip replacements on the go. And so their ability to have this dashboard and to slice and dice it and to filter it in the way they want is very, very important. Next slide, please. So we did our limited production rollout. These are our stats as of last month. Again, it was truly a limited production rollout because we didn't want to boil the ocean on day one. We wanted to work out some of the kinks and make sure we knew what was going on. And so this will show you the numbers in terms of what we've got. We've got a little over 2,000, we're probably approaching 3,000, I think, in the next month of total referrals within the system that are moving forward. If you go to the next slide, and you can actually click after that slide about 10 seconds after the next one after that, you'll just see that the utilization, so for breast cancer referrals, it's going up, and the same thing with the hip and knee referrals, that they're going up as we go down the path, sort of thing. So it's being used more and more as people get used to it and as we've gone through the testing and everything that's there. Next slide, please. So this is how we look at the evolution of our referral system. In the past, we had a lot of variability. It was basically hit and miss. Everybody did things in a different way. We've moved into standardizing the process where we know what the information requirements are. We know what some of the response times are. We know how the triage categories work. We're now well into the automation phase where we can track referrals. We can match services to referrals. If we see capacity issues coming up, we can start to flex around those needs to change the capacity. There's fair transparency in that people know the status of a referral and what's going on. Patients have a choice. They can say, I want a referral to a service, I want a referral to a specialist, I want a referral to a specific hospital, I want a referral in a specific city. And we can capture the wait times and show them in real time. So as we're doing the referrals, if the patient says, I want to see Dr. X, we can show them, okay, but that will be 9 months from now. Is that okay? Well, no, that's not okay. Well, what about Dr. Y? He's got a 5-month waiting list. Would you rather go with him? And so we've got that point. We're not quite at the last step. We're working on it, but certainly our integration, our interoperability, as everybody knows, there's usually a plethora of different EMRs that people use, and making sure we have interoperability with all those EMRs takes a little bit of time, but we're in the process now of building those as well, building those pipes. Next slide, please. So our goals initially, we wanted to support both the ability for a referral for advice and a referral for a full consult. We wanted to have a single go-to place to do your referrals where you could see what was going on and track things. We wanted that transparency where you could actually tell what was going on in terms of wait times and what the status of the referral was. We wanted a system that was truly at a provincial level patient-centric as opposed to provider or organization-centric. And we wanted to create some simple reports where we could actually look at what was going on and get our analytics up and running and start to make decisions. Those things we've done fairly well. We're now into the long-term criteria. And so the next step after the limited production rollout, of course, is to roll this out to a whole bunch of other systems in terms of different referrals. And we're looking at creating a critical mass so that this becomes the go-to tool. It's not there yet because we've just started. We're looking at standardizing a lot of our referral requirements, and this is the perfect tool to get people to sit around a table and try and standardize things. One of the areas we're doing that in right now is urology. We have a real challenge with some of our urological referrals where the wait times are up to 2 years sometimes, and you refer to one and you wait a month before you hear back and they say they're too busy, and then you refer to another and it takes a lot of time. They have all agreed to get together now and have a standard referral process and work on this system, and that will dramatically change the frustrations that we deal with in trying to do urological referrals. We want to track the care transitions over time. So sometimes we think of referrals as being simple things. Often referrals can be thought of as a care transition where somebody is going from one institution to another. They may be going from, say, long-term care into a hospital, or from emerge into a hospital, or from family medicine into long-term care. Those can all be considered forms of referrals, and we can make use of the system when it comes to care transition and looking at some of the bottlenecks we deal with there as well. We want to support research and resource planning, and that's where our analytics comes into play in a big way. We want actual wait time reporting. We want to be able to actually show the powers that be, in particular the fund people, the people that resource us, where the bottlenecks are and what resourcing could do in terms of changing some of the capacity problems that we have. And of course, we want to integrate with all systems. So the holy grail of all of this is true interoperability, and we're working towards that. We're not there yet, but we certainly are moving along that pathway. Next slide, please. So the key insights, what have we learned? We've learned that automating certainly increases the adoption of standards. So if you basically have some hard stops on a referral that if people don't meet the minimum requirements, you can't do the referral, it actually improves the standard of referral. People actually do all the things they need to do before they send it. We want to start to target some of our high referring clinics now that we've gotten past the limited production rollout and start to really get this rolling and get a critical mass so that we can really see and measure the values in a bigger way. And of course, we want that integration piece that I was talking about. We do have some duplication of effort currently with some of our EMRs, whether you have to generate a letter and then go and do the other thing and then attach the letter, which means they got to scan the letter and then send it that way, sort of thing. And so we're working on being able to have that all on the back end work seamlessly between the two systems. And of course, we need to talk more with people. We really need to know, are we doing the right thing? Continue that rapid iterative sort of looping back to sort of seeing, is this meeting the requirements of our users, of our patients, of our medical system, of our funders, all those kinds of things. Next slide, please. So critical to that is communication. Often you can build it, but they don't know it's there. Or you can have certain modules within the system and they don't know how to use them. So communication is critical. And we have a newsletter basically that goes out to all of our providers on a regular basis to let them know what's going on and make sure that they're aware of things. As well, within the Netcare portal, we have the ability of pop-ups in terms of information and those kinds of things as well. So, you know, the key thing when you're building these things, everybody says, is workflow, 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 the top three things that are important when you're building it. The key thing in launching it and getting adoption is communication, communication, communication. And so we have a communication system that we think is making a difference in terms of what we're doing.
Great. Well,
Next
thank
slide,
you,
please.
Dr. Ausford. Thank you for your presentation.
You're welcome.
We're going to go into Q&A at the moment. I do encourage people, there is a question box on your GoToWebinar control panel where you can ask questions. We also have a series of questions that have already been sent in. Dr. Ausford and Dr. Hobson, one of the questions we have is, are external referrals from primary health, such as GPs, being sent electronically into the hospital?
So when you say hospital, I guess I need to qualify that a little bit. We certainly have numbers of referrals being sent to providers who work in the hospital. So yes, yes is the answer, I guess, in the short case. If you're thinking to the hospital in general as an institution, no.
Okay. Do you refer outside of the province or state, and how complex does this become with electronic exchange of information?
So we're currently within the province of Alberta, but we are not referring outside of the province of Alberta. The good news is the Orion Health Information Exchange is actually present in many of our provinces across the country, and so to create an interoperable system would not be difficult to do. We just need the federal government, the country of Canada, to help facilitate how we connect some of those systems together. Even they're all on the same, a lot of them are on the same platform, so it would not be a long stretch to go beyond the province.
Okay, thank you, Dr. Ausford. Another question, is there a patient portal for the HIE? Can the patient see how their referral is progressing? And how interactive can the patient be? Can they be alerted, for example, that they're going overseas for 6 weeks?
So what it comes down to, and this gets into some of the politics of the province and the different systems that we have, there is a patient portal available in Netcare, but we have not turned it on. The patient portals we're currently using are with our electronic medical record system. So for example, Epic that I'm on has a patient portal called MyChart. So it's a bit of a one-off in that we can tell patients what's going on and we can post statuses there, but it's not the same system as we're doing the referrals on currently. The interoperability and integration of that is being discussed right now, but it is not turned on at this time.
Okay, great, thank you. Do you process inbound referrals from GP practice management systems? And if so, do those systems adhere to a standard messaging format to submit the referral?
Well, the messaging format basically is within the system. If you're asking about, say, CCDs, continuity of care documents, or CDAs, we're in the process of looking at those as a standard in terms of being able to attach a CCD to a referral, but we're not currently doing that.
Okay.
I think, sorry, I just interrupt slightly there. I think the point of that question was, if you generate a referral, could you generate a referral in Epic and send that in? I think that was the point.
Okay. So future plans for that. I mean, I can certainly generate a referral within Epic right now, and the one-off issue is that it's not seamlessly transported to Netcare. It has to be scanned in. So there's a one-step thing there between the two because, again, we haven't turned on that interoperability yet.
Okay. I do have another question. Sorry, Dr. Hobson, please.
That's Alan, I think.
I was just going to say that remember that when I'm on my EMR, at the push of a button, I can be in the HIE and see the status of a referral and be working on it. So it's not like I can't very quickly go between the two in terms of viewing. It's just about attaching that I'm talking about.
Great. Okay. Another question from a participant. How did you get a range of GP system vendors to adopt a meaningful standard for integration to submit the referrals?
So we're actually in the process of doing that with our EMR vendors right now. One of the requirements of being a recognized and funded EMR is that you have to meet something we call VCURE standards, which are vendor requirement standards that are set by the province. So if you want to be in business in this province as an EMR vendor, you have to jump through some hoops in terms of interoperability and integration.
Okay. There's a good question, interesting question about pharmacies, Dr. Ausford. What's the level of activity of eReferrals to and from community pharmacies? Is that relevant?
Currently, we're not doing any referrals to pharmacies. Certainly, most of the pharmacists in this province make use of Netcare and are looking at data within Netcare, not just medication data, but also referrals and all kinds of things that way. We don't actually do a referral to a pharmacy. If you're talking about e-prescribing, that's a separate system than through the referral system. But I mean, and again, maybe the situation where they're asking the question is different. Pharmacies in our area basically are around dispensing medications and providing pharmaceutical advice, but they're not doing anything beyond that.
But the pharmacist could review the referral should they want to. Say if the patient's been referred to general medicine or orthopedics or whatever, the pharmacist would have access to Netcare. And by that method, they could see the referral.
Yeah. Absolutely.
Right. We've got a couple more questions, and then we'll bring the presentation to a conclusion. What was the engagement process with general practitioners, and what was the uptake amongst general practitioners, Dr. Ausford?
So the engagement process basically was through a lot of communication vehicles. A lot of presentations were done in terms of rounds. There was systems being sent out. Our regulatory body, our College of Physicians and Surgeons, was involved in sending messages out as well. So there was kind of a variety of ways that we communicated it out. We didn't mandate that you had to use the system, but some of the places that were receiving referrals would redirect people to use the system because then they could track what was going on. And so they had a bit of a feedback loop from that perspective as well. But again, we were a limited production rollout, so our big engagement challenge is coming. But from the feedback we've had from the current users and everybody else looking at what's going on, we're not anticipating a big problem in that area.
Okay, great. Just in terms of the design and implementation, what level of documentation was provided by the vendor, and how much did Alberta Health have to create from scratch?
Chris, you want to start with that one?
There's two ways to that. I mean, the first point is just to appreciate that this was an agile sort of iterative approach to building the configuration, and so at some level, the whole point of doing it in an agile method is to try and reduce the sort of rigid document-heavy approach to things. Everything that, all and every part of Orion product is accessible via our own, for clients can access, product documentation and a wide range of documentation available electronically via access to the Orion document wiki, which all our clients have.
Great, thank you.
I should also add that, the principle-based approach that we had some basic high-level principles that needed to be followed on the basis of doing referrals, and then we also had specific design principles that had to be applied in terms of how we were making the system, the GUI of the system, and how it was apparent in that. And that made a big difference in making sure that we didn't go off track without having to get into high levels of documentation.
Okay, I've got another question from a participant. You mentioned secure messaging early on. Can you discuss the secure messaging a little bit further, please?
Sure. Maybe I'll start by saying that the messaging we have currently within the portal is very basic messaging. It's secure because you have to log in order to send the message, and the message stays within the system. Orion also provides something called direct secure messaging that Chris can talk to. We have not turned on direct secure messaging in our province yet.
Right.
So direct secure messaging is a protocol that some of you may be familiar with. It's fundamentally it's a US protocol implemented by the Office of the National Coordinator for Health IT in the US, and it offers the ability to securely send a message with all of the appropriate and federally approved standards, basically across pretty much anywhere from one HIE to another, that kind of thing, across the United States. Now, we are very keen to promote the use of that both in Canada and other countries such as Australia and so on. At the moment, direct secure messaging, according to the US protocol, is not implemented in Canada or anywhere outside the US. It is one of the most used functionalities that we have in our HIEs in the US, and that sort of explains why we're so keen to take it elsewhere.
Okay, great. A question about clinician involvement. How did you get clinician involvement and buy into the system, and what methods did you find most effective?
Are you talking on the design side or on the utilization side?
I think we're talking on the utilization side.
So I think the carrot, if you want, we didn't use any sticks. The carrot that we used to get people to use it was the fact that they could see very quickly what the status of the referral was. And we have a number of areas, especially in our pilot, in our limited production rollout, where there were really long delays and real challenges in terms of getting somebody with lung cancer was waiting a long time to get something done at the Cancer Institute. So it didn't take much to get engagement when we said, look, if you use this system, you'll be able to see what's going on, and you'll be able to make sure you get the referral to the right person, and very quickly you can track whether or not it's going, on the timelines that you think are appropriate. So from the limited production rollout perspective, I think it was fairly easy. As we move into other areas, it'll be a learning curve for us to see whether or not there's some things we're going to need to do to try and engage a little bit more. Certainly, if you go to one system to do all your referrals, once you get used to that, I think we'll have good engagement. Right now, because we don't have all referrals for all things in the province on this one system, there will be some challenges.
Okay, great, thank you. One person wants to know, they said that there's a referral status of completed. At what point in the workflow is a referral considered completed?
So we spent a lot of time defining that. That's a great question. Completed means that the patient has actually seen the provider has finished whatever they need to do and does not need to see the patient any further. So completed it means that they're completely done, completely returned back to the primary care provider. If there's a series of visits required by a specialist or there's follow-up required by the specialist, that would not be stamped as completed.
Great, okay. Are the referral contents mainly free text, and what sort of clinical contents are structured?
So the pick lists that you have where we set criteria or minimum criteria for things required is structured, but they're simple pick lists that people go through in terms of, for example, for the hip and knee, are they on an analgesic? Is the analgesic a narcotic? Are they using a PRN or are they using it all the time? Those kinds of things are all done as quick pick lists so that we do have the structured data, because it actually generates a score automatically for the triage person. If they're a 10, they're a low priority. If they're a 200, they're a high priority. And so that structured scoring system really makes their job much easier. At the same time, there is some free text that you can do in terms of providing temporal context and some of the other issues that are going on as well.
Great, thank you very much. Another question, to what degree does the system rely on Alberta's central patient record so the referee doesn't need to re-enter patient information? Or does all the information come from the source EMR?
We have a province-wide enterprise master patient index, and so we leverage that heavily. And so that is the single go-to place right across our province. And so because of that, that's what you need to do. When you're doing the referral, however, there is the capability of putting some additional information. One of the things we have is the phenomenon known as snowbirds, where in the winter, some people from Alberta don't like 40 below weather for some reason. And so they go to Phoenix, which is where Chris lives, and they like to take in the 40 above weather. And so those people may have another phone number, and we can enter some of those things over and above what may be in the Enterprise Master Patient Index to make sure that that additional information is there if they need it.
Great. We'll take
I think also, just in addition, sorry if I just interrupt, so as the recipient of the referral, I can view the referral and I can view the whole of Netcare. So the referral letter comes in, I can view what that's about and the details, but I've also got automatically, or just as out of the box, so to speak, access to complete province-wide interactions with that patient with the health system.
Great, thank you. We'll take two more questions. The question is, do providers maintain their own entry in the service catalogue? And how successful have you been in keeping the service catalogue current and up to date?
That's a great question. So we allow for more than one way of doing it. We actually have some systems already. For example, our College of Physicians and Surgeons has a registry for all doctors, and we import data from there because we find that is the most complete database, because you don't get your license unless you fill that out every year. So we know that people have to do that one. And we grab that data and we put it into the health services catalog. We also allow the ability to go in and adjust the health services catalog on a go-forward basis as well.
Great. We'll take a final question. Was there a user training program?
Yes, there is, and it's an online program. We have had very, very good luck with it in that it's generally somewhere between 15 and 20 minutes long to learn the basics, and then if you want to do more, you can.
Great. Dr. Ausford and Dr. Hobson, I just wanted to know, do either of you have any final comments before we end today's session?
You first, Alan.
Okay. Just that, this is a learning process. Like I say, we're a limited production rollout, but we have found we have had very, very positive things in terms of feedback from our users. Probably the most positive thing we get, and the one that's sort of universally, is they now know the status of a referral. They can track what's going on, and that is huge in the minds of our providers. So we're really looking forward to going the next step in terms of rolling this out in a much bigger fashion now.
Dr. Hobson, do you have any final comments?
Yeah, I mean, I think the close partnership between the vendor and the client and clinicians is really huge in this. I think having the really strong support from the Alberta government, so from the top down, and I think that helps, and it comes up in multiple different ways, but the publicity around this is really good. And then, finally, is just having something that really makes value. So as Alan said, you actually know what the heck's going on with your referral, and that solves a problem that in the paper world is very, very difficult. So that's the value of what you ultimately have here is huge, and that's a big piece to the success.
Yeah, and I'll just add that, you know, the people receiving the referral have made huge comments about the fact that their workload has dramatically gone down because they're not sending half of them back for more information.
Mm-hmm.
That's great. Well, Dr. Ausford, Dr. Hobson, thank you very much. I'd like to thank Orion Health for bringing you today's webinar on understanding the Alberta experience in terms of rolling out an e-referral system. I'd like to thank all of our audience for joining us. We will be coming back for another webinar towards the end of the month, and we'll keep you informed. And thank you again to everybody who asked questions today. We hope that your curiosity was satisfied. Thank you again. Good morning. Goodbye.
Thank you.
Thank you.